Hi, everyone. Thank you so much for joining us on OsteoBites today. We are so happy to have you join us for this special Taco Thursday. I know it's usually Taco Tuesday, but today it's Taco Thursday. My name is Christina Iptoma, and I am mom to Osteo Angel Dillon and Director of Scientific Programs at MIB Agents. And today on OsteoBites, we are joined by Dr. Andy Livingston of MD Anderson Cancer Center, who will be discussing the background and scientific rationale for combining immunotherapy with cabozantinib in teens and young adults with osteosarcoma. And he'll also provide information about the ongoing clinical trial currently underway at MD Anderson Cancer Center called the TACOS trial, which is a phase 2 trial of Atezolizumab and Cabozantinib in osteosarcoma. Thank you so much, Dr. Livingston, for joining us on OsteoBites today. We are thrilled to have you. I also want to congratulate you on the genius marketing with the trial name, because I'm sure that garners a lot of interest. People think they're signing up for like a, Tex-Mex tour of Houston, but they're really signing up for this really interesting trial, which is also pretty cool. So thank you, and thank you to Walker and Kara, our panelists, for joining us today. A little bit more about our guest today. Dr. Livingston is a clinician and researcher in Sarcoma Medical Oncology, and he holds a joint appointment in Pediatric Oncology at MD Anderson Cancer Center in Houston. And after completing medical school at the University of Texas Medical Branch in Galveston, he went on to residency training at Duke University, where he completed a combined residency in internal medicine and pediatrics. Dr. Livingston completed his fellowship training at MD Anderson, where he served as a chief fellow for the Hematology Oncology Fellowship Program, and he has a particular interest in the care of teens and young adults with cancer, and he's the co-director of the MD Anderson Adolescent and Young Adult Oncology Program. His clinical and translational research is focused on developing new treatment strategies for patients with osteosarcoma and other bone sarcomas. He received the MIB OutSmarting Osteosarcoma grant in 2020 for his work on the immune landscape of osteosarcoma, and we are honored to have him on our MIB Scientific Advisory Board. And so we're really looking forward to talking to you about TACOS today, and some announcements and reminders before we get started. For our scientific community in the US, OutSmarting Osteosarcoma Research Grant applications are due tomorrow, January 26th in Proposal Central. So hopefully if you're considering applying, you've already started the application. There's a $100,000 one-year grant and a YI $50,000 grant, and we will have multiple awards this year. And the application is relatively short and brief. And Dr. Livingston was actually one of our recipients in 2020, famously right before COVID started. So we were able to award that to him in person before lockdown got going. And then save the date for 2024 Factor, which is our annual conference. It's going to be June 20 to 22nd in Cleveland this year. Factor is really unique in that it brings together everyone in the osteosarcoma community: clinicians, researchers, patients, caregivers, patient advocates, funders, and industry. You will come to collaborate and you will leave re-energized and inspired. So I'll put some links in the chat about that as well. Walker and Kara, could you please introduce yourselves?
Yeah, hi, my name is Walker, and I'm part of this year's MIB Junior Advisory Board. I'm an osteo warrior. I was diagnosed in 2018 and then have been NED since about 2020. I'm really excited to hear about the presentation today, and I'll pass it off to Kara from there.
Hi, my name is Kara Skrubis. I'm on MIB Agents Junior Advisory Board, and I'm also MIB Agents Social Media Manager. I was diagnosed with osteosarcoma in January of 2020, and I am a left above the knee amputee. I'm also super excited to be here, and I'll send it over to Dr. Livingston.
Awesome. Thanks, everyone. Well, thank you so much for the invitation to be here, be with this group, and to share some of our work and ongoing clinical trial that we're excited about. Let's see if we can get it up and running here. Let's do it. Okay, great. So I have a lot in store for you today, but mainly focused on one of our specific clinical trials. As a clinician and researcher, we have a lot of ongoing studies here at MD Anderson, and that we participate with other centers around the country, specifically for patients with osteosarcoma. Today, I wanted to share with you about a specific phase 2 trial we're doing which looks at atezolizumab, and it's an immunotherapy combined with cabozantinib, a pill-based treatment that many patients with osteosarcoma may receive. And we affectionately call this trial TACOS, an acronym for exactly that, atezolizumab and cabozantinib in osteosarcoma. So just want to talk real briefly about why would we even look at or consider immunotherapy for osteosarcoma. Look at some of the research we've done here that supports this idea of how does the immune system interact with the genome or the genetics of osteosarcoma, and then spend most of the talk talking about, hey, why should we combine these drugs and what specifically are we doing in this clinical trial? So very briefly, as many probably know, osteosarcoma is a disease or cancer that we know has existed for a very long time. Every once in a while, I'll Google this and just find older and older reports. And the oldest I found recently suggested that osteosarcomas can be seen dating back more than 1 million years ago, in part because these bony tumors are well preserved. So it's been around a long time. And there's actually been a longstanding interest in using immunotherapy approaches for treating sarcomas and osteosarcomas. And kind of one of the initial famous early reports was something called Coley's toxin, using basically injecting streptococcal organisms into patients who had a tumor that couldn't be resected. And this is kind of some of the famous initial treatments with ramping up the immune system against cancer. But in much more recent time, one of my mentors, actually, Dr. Jeannie Kleinerman here at MD Anderson, did a lot of pioneering work looking at a drug called MTP or mifamrotide that worked really differently than the chemotherapy we've been using, in part by activating the immune system called monocytes and macrophages. And this work even led to a number of clinical trials and drug approval outside of the United States. But more recent trials where we're thinking, can we improve on the backbone for osteosarcoma treatment, most often MAP chemotherapy, like the Uremos trial that looked at the addition of interferon, really didn't show any additional benefits of adding immunotherapy. So we're really trying to understand what's the interplay of the immune system with osteosarcoma, how can we leverage that to improve outcomes for our patients. And so when we think about the interplay between the immune system and cancer, it's complicated. That's probably a short summary, but we think early on when cancer or precancer cells develop, our immune system, things called T cells, NK cells, can work together actually to eliminate and prevent a tumor from forming. At some point, we get to this state called equilibrium, where the immune system's trying to fight back that cancer, but eventually by acquiring more genetic instability, mutations, and otherwise, cancers begin to evade our body's immune system. And this is sometimes called immune escape. And that's where we might see a cancer progressing or spreading because of these other signals, things that block the body's immune response and may inhibit the body's ability to basically attack that cancer itself. And so now, what was groundbreaking and literally Nobel Prize winning work has now been around for more than 10 or 15 years in the clinic, is looking at what's called immune checkpoint blockade or immune checkpoint inhibition. And so, Professor Jim Allison, who's here at MD Anderson, famously won a Nobel Prize for this work. But what they were looking at and thinking about is how does the immune system and T cells interact with a cancer, interact with a tumor? And we see actually these T cells that go in and try to attack cancer get high levels of these, basically these breaks on the T cells that we call immune checkpoints that have names like PD-1, CTLA-4. And what they found is that actually if you block these signals, so anti-PD-1, anti-CTLA-4, many of the immunotherapies we're using in the clinic now for all kinds of cancers, these can basically reinvigorate or stimulate the body's anti-tumor immune response. So groundbreaking, but now kind of everyday clinical practice in oncology. So as these drugs were first coming to clinic, of course, we were looking at them in all adult cancer types, then in pediatric cancers, and really wanting to bring them forward in osteosarcoma. But unfortunately, when we brought these to the clinic, drugs called pembrolizumab, nivolumab, ipilimumab, atezolizumab, these are all examples of immune checkpoint inhibitors. And although these studies were really small, we didn't see that there was much going on. When we treated patients with osteosarcoma with these medicines in the clinic, unfortunately, we didn't see much in the way of responses. So I just briefly summarized a few of the pivotal studies here, but the summary is the same. Across these different studies, these different immune checkpoint medicines, we really didn't see that it was having much effect or helping kids and young adults with osteosarcoma. So actually, that is been a big focus area for our team, my team here at MD Anderson, trying to understand what is it about the biology of osteosarcoma that makes the immune system work or not work. And we published this work a few years ago now, what we call the immunogenomic landscape of osteosarcoma. But again, really trying to understand what's the interplay between the DNA, RNA, the genomics of the tumor itself, and how does that influence the body's anti-tumor immune response? So I'll just go through a couple of the key findings that I think were particularly relevant, especially as we think about the TACOS trial. So in this work, we took a lot of samples, patient samples, actual tumor samples from kids, adults, primary tumors, metastatic tumors, and we looked at all kinds of sequencing, the DNA, the RNA, and one of the things we looked at is what is the immune level? And we can show this a couple different ways. One is by giving it a score, we call the immune score. And two is this, what we call a heat map on the right side of the screen. And basically what I'm showing you is if we look at the different levels of immune genes and all these osteosarcoma samples, we can kind of divide them into three groups. So on the left in blue is what we would call cold or immune cold, basically tumors where we don't see a lot of immune cells infiltrating the tumor. We don't see much going on. And then on the right-hand side, we might call those hot or immune infiltrated. So we see these kind of three separate groups. Osteosarcomas maybe can be divided into three different groups in terms of the immune response or the immune cells that are going into the tumor. So we wanted to start understanding, well, what's different between these? You know, each osteosarcoma is so unique in terms of its biology and its genetics. What's the difference between these, or how can we compare them? And so one way we can look at that is looking at pathways or genes that are differentially expressed. So what's going on between the cold tumors and the hot tumors? And actually in these, what we're calling hot or immune infiltrated, upregulated osteosarcomas, we actually see, not only do we see the immune cells there, but we see high levels of these inhibitory pathways, these things that are tamping down the immune response. And this is going to be a flashback here to what I was just talking about, but high levels of things called PD-L1, high levels of signaling in the CTLA4 pathway. So these are the blockade, these are the brakes. So even though the immune system is there and doing something, clearly there's some brakes, some other pathways, some inhibitory signals that are keeping that immune system from really attacking or potentially eliminating the osteosarcoma. So we can look at that same question in a different way. Again, we're kind of comparing those clusters, 1, 2, and 3 osteosarcoma samples, and trying to figure out what is different between these. What are the differences? And interestingly, here on the left, remember, cluster 3 is that hot or immune infiltrated cluster. We actually found that those infiltrated ones, we have high levels of this immune checkpoint called PD-L1. Remember that because atezolizumab is an anti-PD-L1 drug. Okay, so we see that's upregulated. We can compare these across the groups. And we found some other interesting findings. For example, another signal called TGF-beta, really highly expressed there. And one of the things TGF-beta can do is something called immune exclusion, or basically it's a signal we think that prevents those T cells from getting into the tumor, infiltrating the tumor. So this gave us a lot of ideas, a lot of leads about why not our immune checkpoint inhibitors, why are they not doing what we want them to do? And we could use this data now to go back and say, okay, how can we do this better? What should we be adding? How can we modify the immune response? Can we do better in the next clinical trials based on this data? Okay, so shifting gears a little bit, I want to talk about why would we combine things like immune checkpoint inhibitors with these chemo pills, or more specifically targeted therapy pills we call TKIs, tyrosine kinase inhibitors. So there's all different ways to treat osteosarcoma. While the initial treatment's pretty standardized, if the cancer comes back or spreads and we start to think about some of the options, one of the approaches that's really in the clinic, has been relevant and in the clinic now over the last few years, is using targeted therapy pills we call TKIs, or tyrosine kinase inhibitors. So what do these do? Basically, these are pill-based treatments that block certain receptors or pathways that are on the surface of osteosarcoma, and that basically by blocking these receptors, tyrosine kinase receptors, we can shut down some of the growth or signaling pathways in the tumor. And so many of these drugs, TKIs, actually have multiple targets, so not just one area or one signal or one pathway they're shutting down. But for most of the treatments now that we've seen moving into the clinic, most of them at least hit this pathway we call VEGFR, but may also hit some of these other receptors shown here, as well as even more targets that aren't even shown here. But VEGFR, so this is a vascular growth factor that's highly expressed in a number of cancers and osteosarcoma, of course. And we think by shutting down these receptors, shutting down these pathways, we can shut down the cancer growth. So what do we know about these drugs in osteosarcoma? Well, quite a bit, actually. This is just a slide I borrowed from the Children's Oncology group, but that speaks to some of the recent phase 2 data of using these medicines, tyrosine kinase inhibitors, in osteosarcoma. So on the left, we see the unfortunately poor outcomes for most patients when they have osteosarcoma that comes back or spreads. And this is actually based on data from prior studies of the Children's Oncology group, which just shows that without effective treatment, these osteosarcomas try to grow and spread pretty quickly, even within 4 months time period. But medicines, tyrosine kinase inhibitors, like a drug called regorafenib, or more recently, a drug called cabozantinib, can be pretty effective treatment for patients with osteosarcoma, at least working, for some patients for many months or longer in terms of stopping the growth and spread of the cancer. At this point, there's actually been several clinical trials looking at these medicines in the clinic, and we see that across different TKIs, different targeted therapy pills that have been tried in osteosarcoma, there's actually several that seem to work pretty well. They're similar but different. And so here you can see the names of some of these, like the drug regorafenib, cabozantinib, lenvatinib. And so these have already been evaluated in separate clinical trials for patients with osteosarcoma. And what we're seeing here, it shows you what are the targets. Again, several of these surface receptors that they target. And when we look at how well do they work, one way to look at that is called progression-free survival. And what this is telling us is that these medicines can work well for patients with osteosarcoma, but kind of a limited benefit, maybe 4 to 6 months, sometimes longer, of course, sometimes shorter. But, we wanted to think, okay, that's a good starting point, but of course, how can we do better? So this data here is actually from the published phase 2 trial of cabozantinib in patients with osteosarcoma. The study is called CABONE. It was published in 2020. And so you can certainly look that up, get some more of the data. But what I wanted to show you here is that, this medicine does work for patients with osteosarcoma. So in this study, they only got the pill, cabozantinib alone by itself. And on the left, I'm showing what's called a waterfall plot. And in this type of picture, each line represents a patient's tumor size. And so each of those bars that are going down actually mean patients where the tumor is shrinking. And you can see that for many of the patients with osteosarcoma treated with cabozantinib, that either the pills were able to stop the growth or to shrink the osteosarcoma tumors. And some of that data is summarized here. But on average, that strategy worked for a little more than 6 months. So again, we know that this is a medicine that works and can work well. And so we thought, how can we make it work even better? So that brings us to this idea of combining these tyrosine kinase inhibitors, these pill-based treatments, with immunotherapy. Can we do better? Why or how do these work? What is it about these TKIs, medicines like cabozantinib, that might actually work to boost the immune response? So here's just one review or schema that explains some of the ways we think that works. So when cancer cells grow and tumors grow, we think that they have an inadequate blood supply. And this can result in low oxygen levels called hypoxia. Part of this process is an increase in VEGF. So this is the vascular endothelial growth factor. And from that promotes new blood vessels growing into a tumor. But usually these are not normal blood vessels. So we call this neovascularization, or some of these malformed tumor vasculature. And in this environment, we see that these abnormal blood vessels can really suppress the immune system in a number of ways. Certain things like reducing the amount of anti-tumor T cells called CD8s that can get in there, increasing other immune suppressive cells, things we call Tregs or MDSCs. So basically, even this way the blood vessels remodel within a tumor may actually tamp down or reduce the immune response to the cancer. So of course, based on this, people said, well, why don't we do both? Is there a way we can use these medicines that shut down VEGF, shut down the blood vessels, and at the same time can try to increase the anti-tumor immune response? And I want to share with you, this is a strategy that's been very successful in a number of other cancer types. So of course, some of the initial studies were done in adult cancers, things like kidney cancer or hepatocellular cancer, using different combinations of immune checkpoint inhibitors with different medicines that block angiogenesis, like these TKIs, including cabozantinib, for example. So this table here, it's just a bit of an overview to share with you some of the combinations that are now FDA approved for treating cancer, where they had a similar strategy. Can we take an immune checkpoint inhibitor, combine it with an anti-angiogenic or VEGF-targeted tyrosine kinase inhibitor? And many of these studies led to new FDA approvals in other cancers. So we said, well, hey, let's do that in osteosarcoma. Why don't we do that in sarcoma? And actually, even there, we've had some precedent about this strategy. So one study I'll share with you is a prior study from Breland Wilkie, who's at the University of Colorado, where she looked at a similar idea across sarcoma types. She took a pill-based treatment called axitinib, combined it with an immunotherapy called pembrolizumab, and they treated a number of sarcoma patients. And what was interesting about this study is it seemed to really work well in certain sarcomas. For example, one we call ASPS. And importantly, this was a sarcoma type where we really didn't have very effective therapies, and this combination really showed promise. So, there's a good rationale for doing this. It's been done in a number of cancers, and we've even seen in certain sarcomas that this combination type treatment can be effective, but really hadn't been evaluated in osteosarcoma. So, if we think more about the genome, about the study we did looking at the DNA and the immune levels in osteosarcoma, we can go back and say, well, how could cabozantinib fit into this picture? So the pill-based treatment in the current study, or in the TACOS study, is called cabozantinib. And actually, we see in other prior published research that just taking cabozantinib can affect the immune response. So cabozantinib alone can increase these T cells that attack cancer, called CD8 positive TIL, and also decrease the immune suppressive signals called Tregs, MDSCs, or M1 type macrophages. And so if we go back and look at those immune clusters in osteosarcoma, we actually see that those tumors that were in this hot cluster, the ones where we think the immune response is high, actually in those same tumors, we see very high expression of the cabozantinib targets, the receptors that cabo hits, with things called MET, FLT3, AXL. And actually, we saw that the patients who had higher MET, higher FLT3, higher AXL, higher VEGF, the targets of cabo, if that was higher in the tumor, those patients also had very high expression of this immune checkpoint called PD-L1. So, we're thinking, therefore, can we do both? Can we attack the cancer with cabozantinib, but also try to get to ramp up the immune response? And that's exactly the idea of this study called TACOS. So in the last part of the talk, I want to share with you more about the study itself. What are we doing? How's it designed? And what type of patients this could potentially qualify for this clinical trial. So this is a phase 2 trial combining these two medicines. And so in phase 2, what are we trying to do? Well, basically the main point or primary objective of the study is to see how well does this work. So patients will get a combination of cabozantinib, the pill-based treatment, along with atezolizumab, the IV infusion immunotherapy. And what we're trying to figure out is how well does it work against osteosarcoma? And so some of the ways we can look at that is called progression-free survival, but we'll also look at the response rates. How well does this shrink tumors? And we have some specific criteria for that. And then lastly, what are the side effects? We call it the toxicity, but how safe is this regimen and what are the side effects? Along the way, we want to learn as much as we can about osteosarcoma biology to understand, are there tumors where this works, tumors where it doesn't work? How can we make it work better? Always trying to think 3 steps ahead. And so some of the things we want to look at in the tumor samples is really, what are the levels of these markers, things called PD-1, PD-L1? What are the levels of MET and VEGF? What do they look like before we start the treatment? And then after we give treatment with cabozantinib, with atezolizumab, are we shutting those things down? So we'll get another sample, another biopsy, and we can compare prior to treatment and on treatment. What's going on in the tumor? Are we hitting the targets we want? And importantly, do we see the immune cells coming in? Is the immune system being ramped up? Is it attacking those tumors? And that really will give us some more insight about how well does this treatment work? Is it doing what we want and what we think? Okay, so here is what we call the schema, but basically can just give you an overview of how the study is designed and how does the treatment work. So as I mentioned, this study is not for patients with newly diagnosed osteosarcoma. It's actually for patients who've had standard treatment and the cancer maybe came back, spread, or the initial treatment did not work as well as we wanted. So in that case, we see, is this the right fit? Is this the right study? And then we're asking that patients provide some amount of tumor tissue, osteosarcoma tumor tissue, around the time we start the study. This can either be, basically a sample from a prior surgery, or if that's not available, we consider doing a biopsy to really look at some of these levels. And then patients go on treatment with the 2 medicines at the same time. So cabozantinib, a pill-based treatment, is a pill that patients would take every day. The second medicine, called atezolizumab, is an IV-based treatment. It's given as an IV infusion once every 3 weeks. So in this way, we think of every 3 weeks as a cycle, and then every 2 cycles or every 6 weeks, we're already getting new scans. Once patients are on the study, we do ask, there is an opportunity or optional biopsy where we'll do another sample of the tumor. That really gives us more scientific insight, like I was saying, trying to understand the biology of this treatment. But in terms of the treatment's ongoing. So about every 6 weeks or about every 2 months, we'll do new scans. So of course, patients have scans prior to starting the treatment so we can see what's going on with the osteosarcoma, where is it, or how big are the tumors. And then every 6 weeks, we repeat the scans with either CAT scan, PET scan, or in some cases, MRI. And if we see that the treatment's helping, stopping the cancer or shrinking the tumors, then patients would continue on this same treatment for as many as 12 cycles. Of course, if we found out that the treatment's not working, then we would stop and, of course, move on to other possible treatments. So I want to talk just briefly about what are the eligibility criteria, who could qualify for this study. There's very detailed criteria available either through our team or also on clinicaltrials.gov. I'll be happy to share the link or provide additional information for anyone who needs it. But I wanted to share some of the key important criteria for this study. Of course, because this is a research study, it's very important that patients and or their families would provide consent for the study. And in this case, the study is looking at patients who are greater or equal to 12 years of age. So it will be teens, young adults, and even older adults. Of course, as I shared, it's specifically for patients with osteosarcoma, and patients have to have at least some prior treatment with what we consider the standard chemotherapies. Most often, this would be MAP chemotherapy, but using medicines like methotrexate, doxorubicin, cisplatin, and ifosfamide. Here it gets a bit detailed, but what I can say in summary is that patients need to be physically fit in order to undergo this treatment safely. So we call this the performance status. Patients must have what's called measurable disease. So there must be a tumor or tumor nodule, like perhaps a nodule in the lung or somewhere else in the body we can measure. This allows us to understand how well is the treatment working. And then some of these other criteria really have to do just with patient safety, thinking about what are the blood counts, what's the kidney function or the liver function. And these rules are designed for these studies primarily to make sure that we can give the treatment safely. Because we're trying to learn as much as we can about osteosarcoma biology, and how the immune system works, we are asking that patients provide some tumor sample, which can be what's called archival, meaning a sample that was previously collected, or that patients would have a biopsy of their osteosarcoma. This can help us understand how to apply this treatment for other patients. And then, very briefly, again, wanting just to make sure that if there's other health issues ongoing, that those are being well managed so that the treatment can be given safely. Some things that are also important, of course, the cabozantinib is a pill-based treatment. Right now, that's the only form it comes in, so patients would need to be able to swallow pills. If you've had cabozantinib previous to this, actually that would unfortunately exclude you from the trial because we want to see how well does the combination work. But if you've had another medicine that's similar, perhaps a medicine like regorafenib, that's okay. So if you ever have questions about that, of course, we can look into that with our research team, see if this would be an option. And similarly, if you've received immunotherapy with other immunotherapy medicines, that's okay, because in this study, actually, we're trying to see, can they work together? So as long as you've not had the combo, then this study may still be an option for you. And then, like many other clinical trials, we have a time period where you need to stop your previous treatment before starting on the clinical trial. And again, what we call this is a washout period, but it really just means we need to make sure that prior treatment's kind of out of the system in order to avoid any potential overlap, interactions, or safety concerns. I think in terms of time, maybe I'll skip through some of these criteria, but again, they'll be available to you if you want to look them up or you have questions about them. Because this is an immunotherapy, certain autoimmune conditions, may exclude someone from the trial because we need to see about giving these treatments safely. If there's any reason to suspect that the osteosarcoma is involving the central nervous system, like the brain or spine, that would need to be appropriately treated first. It wouldn't completely exclude a patient, but that would be a priority issue, and we need to make sure that that's dealt with safely. So these are some of the type of things we look at when trying to decide if a patient would qualify for this study. Lastly, I think one of the really important things we hope to do through this and similar trials is understand, how do these treatments work for patients with osteosarcoma, and how can we make it better? Just like the mission of MIB, we're thinking, how do we make it better for kids, young adults, older adults with osteosarcoma? And part of that is learning as much as we can from every patient, from every treatment and every clinical trial. And so the way we do that is through what we call translational studies. And I've mentioned a couple times in the talk, but it's really about understanding the biology. And it's equally important in understanding the biology when a treatment works well as if this treatment's not effective. And if we have some patients it works well, somewhere it's not working, that's how we can evolve the treatments to understand, are there certain mechanisms or things we can overcome? And so how are we doing that in the current study? Well, we're doing a lot of things, actually, but it's looking at the tumor. It's understanding what's going on with the immune cells in the tumor when we start, what's going on with the immune cells as we're doing the treatment. And the way we're doing that here at MD Anderson is through some of the internal platforms, some of the systems we have set up here that will take these tumor samples, from patients, blood samples from patients, and allow us to do really in-depth analysis through next-generation sequencing, things we call whole exome or whole genome sequencing, RNA sequencing, TCR sequencing, looking at the immune cells. And actually, we can then take this same data now for patients treated on the TACOS study, and we can go back and compare it to that original research I showed you, where we looked at what are those immune classifications, what are those different clusters, and what's the immune score? Because one of the things we want to know is it those patients that have that high immune score, high immune infiltrate? Is that where this treatment's working? Or is this a type of treatment that may be able to take those so-called cold tumors and really drive up the immune system? So these are some of the questions we're looking on the research side that we hope to learn from this study, so we can really broaden our findings to other patients going forward. So currently, this clinical trial is only available at MD Anderson Cancer Center here in Houston, Texas. We are working with a couple of other major centers that we hope that we could expand this study to other cancer centers in the United States in the coming months. But if you're interested, you'd like to get more information about the trial, the best starting point, of course, aside from this talk, would be head to clinicaltrials.gov. If you can't remember all the identifiers here, we'll send out the information, but you can find the clinical trial by using this, what's called the NCT number, or if you put osteosarcoma and TACOS, it should be easy for you to find. And then once you go to that website, you'll also find some contact information for me, as well as my research team. And if you'd like more information, or you're potentially interested for you, a loved one, a friend, a family member, please reach out. We're happy to discuss further and see, is this a good fit? Could this be an option for you? I'm incredibly grateful to the team here. You know, I presented a lot of different research we've done over time in osteosarcoma, studies that have been supported by foundations, grants, and importantly, MIB as well. And this really takes a whole team effort. So it's working together with the scientists and the genomics group, the pathologists, of course, the oncologists who see and treat these patients along with me. So I'm just really grateful for the whole team here that helps support this research and allows us to move forward and make it better for kids with osteosarcoma. If you have any questions, of course, please reach out. You can find me here. And I think hopefully I left a few minutes left for us to have some questions now, if anyone has them. I'd love to take your questions about this study or anything else you'd like to chat about. Thank you.
Thank you so much, Dr. Livingston. And yes, you definitely left us some time for Q&A, which is great. So everyone, if you have any questions, please feel free to enter them in the Q&A section in Zoom. And thank you for so beautifully explaining kind of the rationale for this combo. I think you did a really great job of breaking that down, and just had a couple questions going back to some of your slides. So there was one slide where you were kind of showing the different TKIs and the response rates, and to kind of, you know, justify like why Cabo, which is kind of being used in the clinic. And Apatinib is one of the ones that's on there, and it did have, like, if you look at just the numbers, it had kind of the highest objective response rate. So if you can just maybe talk to that. It did, and also maybe it looked like it was just like a VEGFR2 as opposed to like an MTKI, but maybe you can just speak to why Cabo versus the other.
Yeah, I think it's an important question, and one thing that we're always cautioned about doing as clinical researchers, investigators, is what's called cross-trial comparison, meaning that, you know, of course we all do this. We all look at the data because we're all thinking, what's the best treatment for me or for my child? And if we have all these different ones, if the menu has all these things on the menu, we want to pick the best one. But remember, these weren't evaluated at the same time or in the same trial. So there may be things that were different about the patients who went on to one of these medicines versus the other, in terms of how many sites of disease did they have? Did they start the medicine when the cancer was growing quickly or growing slowly? And so I always say approach it with a little bit of caution when we compare these numbers. But you're right, if we look across, you know, there's been 6, 8, 10 different TKIs evaluated in osteosarcoma. that are slightly different. They're usually made by different companies. They may have different targets, but across the board, we see that almost all of them hit this receptor called VEGF or VEGFR. And so I think that's one of the key. But some of the things that are unique about cabozantinib is also this shutting down a pathway called MET, M-E-T, MET, axilin, FLT3. And so we think that that's really relevant in bone tumors. That was part of the rationale for the original Cabo studies. And we also think that that may also have more interplay with the immune response. So I think, outside of the question of the TACOS trial, actually, there's several good options that in the clinic tend to work similarly. I haven't noticed in my own practice a dramatic difference of one versus the other, but it's more about some of the immune features that we see with cabozantinib that actually we've learned from other cancer types, even adult cancers, using cabozantinib and immunotherapy combinations that made it, really interesting and compelling for this trial.
Yeah, I was going to ask because I was, when I was looking up this particular combo, there have been several trials for other diseases like kidney cancer or non-small cell lung cancer, prostate cancer. I think there was even a MD Anderson trial right now on glioblastoma. And so I was wondering if this is the first trial that's for pediatrics for this specific combo. And then kind of second part to that question is, given that there have been these other trials that I think have been running for a while, have they been doing the same type of translational and correlative studies that you're planning on doing so that you're able to learn a little bit from their studies about who's responded to this combo so far?
Yeah, it's a great point and great question. So the good thing is when we approach the companies about getting these medicines, putting together this study, the good news is because they've already looked at it or were looking at it in other cancers, we already had some of the safety data. We kind of knew what's the right dose, is this safe to do? But actually, as you mentioned, at the time this study was being developed, it was the first time this combination was being used under 18 years of age. So, of course, cabozantinib, we had data, atezolizumab, using that in pediatrics, but combining the two is kind of unique here. But very fortunately, the companies, helped us in putting together the dosing data. And actually, the FDA thought that it was appropriate. We could take this combination, use some of the adult data in terms of safety, and then start bringing these treatments to younger patients, 12 and up. So that was, one thing that's really cool. And then the second part, I agree with you. We can't just look at osteosarcoma in isolation. I mean, it's so different than other cancers. We know that about how it behaves, what it responds to, the treatments that work. But I think we need to really leverage understanding of cancer biology from other tumors to really put that in context, And so I think you're right. If we think about, for example, the combination of cabozantinib and nivolumab, has been FDA approved in kidney cancer, renal cell cancer. So it's a very similar idea, different immune checkpoint inhibitor. And, trying to think about how does that work? Why does that work there? Can we compare that to what we're doing? And so we try to go back, at least on studies that are done here or where we have those samples, and we try to compare, not just looking at the samples that were collected in this study, but how does that compare to other sarcomas? And another way we can learn more about this combo is even just comparing this TACOS combo, right, the Cabo and Atezo, to other studies we've done here. So I didn't go into it today, but we ran a prior study with different immunotherapy here in our group at MD Anderson that included osteosarcoma patients, and they had these biopsies along the way. And now what we can do is, because we house those samples, we have that sequencing data, that immune profiling. Now we can compare between the two and say, okay, yeah, do we see something different with the Cabo in terms of how it's driving the immune response? So it really helps us to understand, what is it doing what we want? Of course, if we see tumors stopping and shrinking, we'll know it's doing what we want, but how does it work? This is such an important question. And to me, I think something really meaningful that osteosarcoma patients can contribute to. I think it's about, obviously finding effective treatments for the patient who's in front of you, but, how can we work together, to bring these treatments to other patients? Yeah.
I did methamertide, which was also an immunotherapy. And for me, I was just wondering, I know that it's like early stages, so you can't necessarily say for certain any possible side effects, but Are there any side effects that you see common with an immunotherapy that you might expect to see with TACOs?
Yeah, so great question. And thanks for sharing some of your story too. Yeah, mifemertide is very interesting medicine. And something I got to learn a lot about. I actually trained in Jeannie Kleinerman's lab, and so that kind of sparked some of my interest in thinking about how do we do immunotherapy. So side effects for the current treatment. In general, immunotherapies tend to be pretty well tolerated. But remember, part of what the immunotherapy is doing or trying to do is ramp up the body's immune system. So while we don't often see reactions to the infusion necessarily, some of the side effects can be due to overactivation of the immune system. So in some patients, we can see really high levels of inflammation, things like inflammation in the lung or in the intestine. And so these are the things we'll watch out for quite closely. And then the other side effects may be the side effects of the pill, right? The cabozantinib. So we need to think about the possible immune side effects, but as well as possible side effects from the pill cabozantinib. And, most often these are things that are pretty well tolerated, vary from person to person, but things like fatigue, sometimes low appetite, sometimes stomach upset or cramping, diarrhea. So these are some of the things we're watching for closely on the treatment. But, I think we're all hoping to find a treatment combination that works well, right, against osteosarcoma, but hopefully has kind of fewer or manageable side effects.
Just kind of a follow-up to that too. Would you, in that case, want to see some of those side effects then as kind of a biomarker that it was taking effect on the immune system?
It's a great question. That's a question that's been around basically as long as immunotherapy has been around, and they've gone back and looked at some of these original trials with nivolumab and others, that idea like, well, hey, if you're having all these immune side effects, doesn't that mean the immune system is really activated? And some of those studies, they did show a correlation between patients who had side effects and having a better response. But I think it's a balance because, of course, if you have a really high immune response or a lot of inflammation, then some of the treatments we give to treat the side effects are like steroid medicines like prednisone or other medicines targeted to slow the immune response. So it's really a balance, right? Because you could imagine you don't want to be ramping up the immune system, but then trying to go back and shut it down. So, we're always trying to find the sweet spot.
Dr. Livingston, maybe you can talk a little bit. So I think you said that the atezolizumab infusion is on day 1, and then taking Cabo as a pill every day. I'm wondering, does all this have to be done on site for people who are considering enrolling at MD Anderson? Can any of the labs or the scans be done at their home institution, or should they plan to be at MD Anderson for the trial?
Yeah, good question. So you're exactly right. The way the treatment is done, of course, if we think through the timeline, if a patient was considering this study, they would come here, we would probably do a number of tests in terms of labs, review recent scans or get new imaging, really make sure, is this a good fit? Do they meet the criteria? But most importantly, is this a good fit and safe fit for that patient? And then the way the treatment is done is that the atezolizumab, the infusion is given through an IV once every 3 weeks, just as you described. The cabozantinib is a pill-based treatment that's taken every day. Early on in the study, we meet with patients weekly to see how they're doing, check their lab work, see are there any side effects. But for patients who continue on the treatment, then those visits become every 3 weeks. And the scans or, to see how well the treatment is working is done every 6 weeks. So the infusions do have to be done here. Early on, some of those visits have to be here. But, in patients who are kind of up and going and doing well on the treatment, then usually the visits are about every 3 weeks. So patients could potentially travel home in between the visits.
And so are those labs, do those also go from 1 week to 3 weeks as well?
Yeah, correct. As we go further along, most of the time we only need the lab work about every 3 weeks, unless, of course, there's something else going on we need to watch more closely.
Great. Oh, and we have a question come in. If Walker, do you want to maybe take that one?
Yeah. The question that came in from the Q&A asks, is it possible at this stage to use some markers from the blood to check how the treatments work? or do we have to do a biopsy?
Yeah, so really good question. For this study, let me talk about this study and then talk in more general terms. But, for this study, we are trying to get tumor tissue as well. But again, on a case-by-case basis, that may not mean doing a new biopsy. Oftentimes, if you've had a recent biopsy, or if you had surgery recently, most of the time there will be what we call archival tissue or tumor tissue that's in the pathology lab or tumor bank that we can access without needing a new biopsy. So that may be an option. And I think, I want to say, don't let that prevent someone who may be interested in the study. I think we always need to look in more detail about what the options are there. How can we monitor the treatments working? Well, there's been a growing interest in using blood-based tests to monitor treatment for osteosarcoma using something called circulating tumor DNA or cell-free DNA. But this is really being done in the research setting. So right now, there's no good blood-based test in general for osteosarcoma, like what we would call a tumor marker to measure how effective is a treatment, even standard treatment. And we don't have a specific immune test or immune signature that can, at this point, predict how the treatment's going to work or if the treatment's working. So right now, it's something we're all kind of working on, looking at and hoping for, but currently we don't have a blood-based biomarker test for osteosarcoma.
You might have mentioned this before, but for the IV treatments, could patients do that peripherally, or would they need a port for that?
These type of treatments could be given through a peripheral IV. Great question. I should also mention it's a treatment that's given outpatient, so something you would do in the infusion center. Typically, patients don't need to be admitted to the hospital or have a longer time in the hospital. I know that's a frequent question I get in my clinic.
I had one question about why you chose atezolizumab as your specific immunotherapy that you're using. Does it work better with Cabo or Cabo better than other immunotherapies, or did you guys just how'd you come to use that one?
Good question. I think it has to do with looking at the combinations, the safety of the combination, and also, admittedly, the support that we can get even from industry sponsors to help support the study. So, as I mentioned, there's been a number of clinical trials that before this one that looked at all different combinations, so different pills, different immunotherapies. Fortunately, these two together had already been studied in what's called phase 1 safety studies and a number of ongoing phase 2 trials for adult cancers. So we had a lot of data that said, hey, you can really safely combine these. So that was one starting point. And then fortunately, this study was brought forward as what's called investigator initiated. So it's not a study that was started by the drug company or but it was more out of our science, our lab, and going to them and saying, hey, here's something we want to do. And the great thing here is that we have some mutual interest and support from the two companies. So we're really grateful. So Genentech is the company that makes atezolizumab, and Exelixis, who makes cabozantinib. And through our negotiations and agreement, they agreed to provide the medicines for the study. And that's great for us because, of course, we want to do the study when we bring this to patients, and also great for patients because patients who are on this study receive the medications at no cost.
A follow-up to that. So in the future, if there's success with this, would you try to match up specific TKIs along with different immunotherapies based on the tumor genome?
Very good question. I think a big part of what we want to understand is, are there specific osteosarcoma patients where this really works well? And because one could imagine, if there's something similar, then maybe we could better select patients for this treatment in the future. So we call that a biomarker, a selection biomarker, a predictive biomarker. That's one thing we want to find out. And then the second part of your question was a little bit about, should we use other immunotherapies or other TKIs? This idea is actually being done in a number of clinical trials, including other trials for osteosarcoma. And so, I would encourage you to seek those out as well. So, for example, one study that has been led by Laura Davis and conducted through SARC, looking at regorafenib and nivolumab, so a different combination. So kind of a similar idea, but two different drugs. And then there's also a study that has been being conducted at another center looking at lenvatinib and pembrolizumab. So, there's different combos, there's different ways this may work. And so, each one's a little bit different in terms of what's the target, how do those combine? And I think we're actually going to learn the most by putting all this data together. So, it's really collaboration that's going to help us answer the big questions that we're asking, which is like, how does this work? Who does it work for? And that's where I'm really hopeful on the back end. Each of these studies is going to collect their data, collect those tumor samples, and maybe by comparing and working together, we can really better answer those questions that, what I think are the burning questions. Of course, this is something we give a lot of thought to, but really understanding how do these treatments work and who do they work for?
Thank you. If anyone has any questions for Dr. Livingston, please feel free to pop them into the Q&A. We have a couple more minutes before the top of the hour. I did have a question about, just again, for eligibility requirements, because you did go over some of the washout periods for other drugs or chemotherapy. And I just wanted to clarify for surgery, in case if someone does have recurrent disease and they do need to have visible, measurable disease, right? So there needs to be something that's like unresectable.
Correct. Yeah. Well, so it's a very good question. So in this study, a couple things. Of course, you can have prior surgery. That wouldn't exclude you. There is a time period that you need to be recovered from the prior surgery before we start. And actually, in this study, as a small study, we're including patients with both potentially resectable and unresectable disease. So in this study, for example, if someone had a number of lung nodules or lung metastasis, they could go on the study. And then after a certain time point, the study actually allows you to go on and have surgery if we think that's in the best interest, around 6 months' time. So we want long enough to kind of see, is this treatment working? And then some patients may choose to have surgery on the study. And in those patients where we think it's in their best interest, the study actually allows us to go back onto the treatment later. But what you described is also completely correct. If someone had lung metastasis or lung nodules, they were completely removed, and kind of at this time point in their disease course, we call no evidence of disease or NED or no measurable disease. Unfortunately, for this study, we don't have that option. But of course, there are other clinical trials that are going on that are really for that scenario. So this wouldn't be an option, but of course, we have a lot of other studies, fortunately, and perhaps one that would be a better fit.
Yeah, I'll just plug, we did do an OsteoBites a couple months ago for the Cabozantinib study, Cabozantinib. So just single agent Cabozantinib for if you're NED. So
correct. Yeah. And another really important question we're trying to ask and answer and understand with this medicine, Cabozantinib. And people here may also be familiar about, there's a current new frontline study run through the Children's Oncology group that's actually looking about, can we add this drug Cabozantinib to standard MAP chemotherapy? So for patients who are newly diagnosed and high risk, there's a current national study through the Children's Oncology group. So you're probably hearing and seeing this word and name Cabozantinib all over the place in osteosarcoma right now, but really understanding what's the best way to fit it in. We know it works by itself. So what about using it for maintenance? What about using it with immunotherapy? What about, can we even make MAP work even better? These are some of the questions we're trying to answer.
I mean, it's actually kind of thrilling that there are so many trial options right now, depending on where you are in the stage of disease, whether you're, NED after recurrent disease, or if you have visible disease after recurrence, or even for this new COG trial that you're talking about for newly diagnosed. I mean, it's pretty amazing that there's so many options for patients right now. So thank you so much for your work, kind of leading one of these trials and providing one of those options to patients. We're grateful for all you do to make it better for sarcoma patients. More information on this and all OsteoBites can be found on the MIB Agents YouTube channel, on our website at mibagents.org, and at your favorite podcast place. And we're going to be taking a break from OsteoBites next week because MIB will actually be visiting our 2023 OutSmarting funded researchers at UC Davis and UCLA. But we're going to be back the following week on February 8th to talk to Dr. David Fryer, who's from Children's Hospital Los Angeles. and he's going to provide a review of hearing loss as a serious and permanent side effect caused by cisplatin chemotherapy. And he'll discuss recent research regarding its prevention and its relevance for young people treated for osteosarcoma. You can find our OsteoBites lineup for the next few months on our website. And if you have any ideas for future topics you'd like to hear about, please feel free to email us at events@mibagents.org. Thank you so much, Dr. Livingston, for joining us today, for talking about this really important study, and to Walker and Kara for joining us and spending an hour with us today, and for your insightful questions. We hope to see you back here on OsteoBites on February 8th when we talk to Dr. David Fryer. Thanks, everyone.